Straight from the Cutter's Mouth is now back with a preview of the May 2021 edition of Retinal Physician. And joining me for this podcast, Dr. Shriji Patel from Vanderbilt University. Shriji, welcome back.
Yeah, thanks for having me.
So let's talk about these articles. So again, all these articles are available at retinalphysician.com. The goal of this is not to go through all the details of the articles. You can read those articles on your own. They're available for free, but more to use them as a jumping off point for discussion. So we have this great article called An Approach to Surgical Complications in Retina. Jake Duker, who's a fellow up at Tufts, wrote this with Carolyn Baumel, faculty there. So they kind of go through step by step the things that can happen that are give us nightmares and are bad, starting with block related complications, with something like a suprachoroidal hemorrhage during a surgery, issues with the IOP during surgery, and what you do in terms of IOP after surgery. And these are all, I mean, these are the things that unfortunately we try to avoid. But when they happen, whether you're a fellow or an attending, you have to kind of go back to your basics and understand how to deal with each one of these issues. So, Sriji, let's just talk about, we could go through them kind of before and after. I think it's a good organization. So they talk about pre-procedure complications or setups. Block is one of them. There's been a lot of discussion of subtenons or cut down blocks versus peribulbar versus retrobulbar block. But what do you do in your practice? I mean, do you guys routinely block? Does anesthesia block? Do you block? Has anyone in your practice completely switched over to cut downs? What are your thoughts on this issue?
Yeah, I thought it's a really interesting debate ongoing for a while now. I do all peribulbars, and so I do it myself, or the fellow does them. We're essentially using a short 25 gauge needle that kind of wraps around the eye. I like the cut down also, but the only difference is I get to do this block before prep, which I prefer because then I think it gives a little bit of time for it to kind of settle in while you're doing the prep and everything. So you could take an easy anesthesia by the time you start. I find that it's great. It's really low risk. I don't worry about globe perforation at all. People don't have to stop blood thinners. You're not going to get retrobulbar hemorrhage. Worst cases, you get a little bit of subconch hemorrhage, which will take any day of the week. And so I like that block a lot. I really don't do retrobulbars. I think there's a place for them certainly, but some of the things that they talk about in this article are the concerns that I have, especially in patients that are at risk, whether they've had previous surgeries or axial myopia, things of that nature. Obviously retina patients can be complex with complex ocular histories. And so we want to kind of level the playing field as much as we can. We won't go to anesthesia, but we don't want to start behind the eight ball in case where we've caused bleeding in the back of the eye or something like that.
Yeah, I had attendings in fellowship who only did subtenons, and I have friends who trained at that fellowship who only do subtenons. I think a lot of it depends. I'm curious. I do a peribulbar as well, and I use the short needle for the same reasons. But we use hyaluronidase with our blocks. I don't know if you do as well at your facility. You're nodding yes.
We do, yeah.
Yeah, so I think that changes things because some places you don't have that. So I remember in fellowship we didn't use hyaluronidase routinely. So if you're not in the cone, then your peribulbar may not be as effective over time. But I still like
Sure.
the idea of the peribulbar with then a supplement as needed on the field. If you need to add more, you can always add more. I agree. The subtenons, people might say there's no disadvantage. I agree with that. I mean, think of well done subtenons. You don't get the chemosis. You can really get it back there, and it's safer because it's usually a blunt cannula. I agree that the prep can be a little more difficult. Patients are often squeezing or uncomfortable with the betadine if you're trying to do the lashes.
Exactly, yeah.
And then the lash prep, like I feel like if the eye is not as proptotic, you can get good lash prep. But if the patient's squeezing, if they're feeling it, obviously cataract surgeons achieve it. So I'm not saying it's impossible. They do it with topical anesthesia and they can do it. But
Right.
sometimes, especially for like IOL cases, and we'll talk about IOL cases, I found that sometimes it's a pain because if you're doing an IOL case, you need a superior tunnel, you need good access, the orbit's a little deeper, and you haven't proptosed the globe, and then you have lashes kind of where you want to work. You might have to take a little extra time then to take a tegaderm or something like that and tape the lashes back. And it's not, again, it's not the end of the world. I do subtenons for certain situations where, a peri may be not as warranted. Blood thinners we can talk about, or anticoagulants, but I haven't really had any issues with just the peri and subtenons as needed. So I kind of do the same thing.
Yeah.
Um, in terms of suprachoroidal hemorrhages, thankfully I've only had this happen a couple of times during a case. Um, I find it's almost always, obviously it can happen due to hypotony. If you get sudden hypotony during a case, it's bad. But I find it's almost always in like high myopes who are having like a buckle or a buccal vit. And for whatever reason, I've had maybe two of these cases where they'll suddenly develop suprachoroidals, One was just going to air, and maybe there's transient hypotony with that switch. Maybe there's an airlock in the infusion.
Right. Yeah.
And then the other was just random. We started the vitrectomy, and also we noticed there was a suprachoroidal developing, and increased the pressure, and it resolved post-operatively. I mean, they talk about ways to prevent it, right? Blood pressure modification, anticoagulant, avoiding hypotony, or avoiding drastic changes. This not having your infusion cannula go into suprachoroidal space, really important. We talked about that in their
Yeah.
complications episode. What about if it happens, right? So would you do? So you get suprachoroidals. What's your kind of instinct to what you do as a reaction? Do you ever drain acutely? Do you ever stop or abort your surgery? What would be your approach if you are a surgeon who encounters this?
Yeah, definitely only a couple times. I agree, it occurs almost at random. One, I remember a patient coughed during the surgery, which we have time and again, and all of a sudden they started developing a suprachoroidal hemorrhage. First thing I do is I confirm that the infusion is where I think it is, because if that infusion went into the suprachoroidal space and led to a serous choroidal that transitioned to a hemorrhagic choroidal, that is an issue that'll keep on progressing if you don't identify it. So I identify the infusion, make sure it's in the right spot. If I need to transition it to another cannula, I go ahead and do that. And I stabilize the eye. I try and increase the pressure, try and get the hemorrhaging to stop, make sure that the blood pressure is controlled. I make sure I look at the screen, make sure that they're not having, hypertensive crisis or anything peculiar like that. And then at that point, I assess where we are in the case, and I make sure that we've done what we're there for, the critical portions. But then I get out. I suture every wound, I take the cannulas out, and then I just try and stabilize things. Because in my experience, these eyes go south quickly. And I remember a specific case of a cataract surgery where I was just, assisting, and I saw that. And so I try not to belabor the process and stay in the eye too long, try and stabilize, and then kind of reassess, live to fight another day.
What about like, I think we get, I always think like if I have a case that has choroidals, happened a couple of times. What do you do in terms of your IOP goal / management, right? Because one of the reasons the suprachoroidal may progress is if you're hypotenuse. However, you could be concerned that your suprachoroidal hemorrhage will result in high eye pressure, which is the last issue they talked about, right? So like I always sit there and I'm like, well, for example, do I want to give this patient a carbonic anhydrase inhibitor like acetazolamide, right? Like, do I want to give it to prevent hypotony or to prevent elevated IOP post-op, or is it a bad thing because maybe they're more hypotenuse than I want? Or if I'm choosing a gas, we're always taught, well, if you want a good fill, use like an expansile bubble. And I think that's reasonable, but then you may have to balance that against the risk that the next day the pressure is 50 and the chamber is flat because you've got choroidals and this bubble that's expanding, especially if they're hemorrhagic and you haven't left a drain site. So like, what's kind of, if you do have that kind of case, what do you do in terms of IOP management at the end of the case?
Yeah, that's a great point. I would be very concerned about hypotony the next day, because that would, in my opinion, make the hemorrhagic choroidal worse, because they could just keep on progressing even after you leave the eye. So that's why I'll suture everything, and I try and err on the side of a slightly elevated IOP. The way I kind of think about that is elevated IOP I can do something about. Low IOP becomes a much harder issue to treat, and especially if the choroidal has progressed after you've left the case, things can get much worse. And so if their pressure's high, I can do a gas tab. I can figure out ways to lower the pressure as needed. I agree. I don't want the pressure to be 50 with a flat AC, because that's that may require urgent return to the operating room. But higher IOP I can do something about. So I tend to have a little bit of a higher, I lean towards a higher IOP at the end of these cases.
We did a complications episode about things that can happen wrong during surgery. We didn't really talk about IOP. Actually, that'd probably be a good topic for a future episode, is like managing post-op complications that commonly happen. What do you do? Because I think there's a lot of different options and people have different opinions, but there's some good principles to it. And I talk to the residents about IOP a lot too, because they'll see sometimes these urgent patients through the ER who are retina post-ops, and kind of knowing how to manage the IOP. First, you have to kind of understand what's the mechanism depending on the timing of it. So the last part of this write-up, they talk about elevated IOP, and they talk about what are the things that can increase IOP. Obviously, a tamponade, and when is the expansion, and maybe using the wrong gas concentration could cause disastrous consequences. Buckles are more likely to potentially increase the IOP. You could get steroid response later. You can get issues with oil. It could be angle closure. I mean, just kind of troubleshooting this are things we're used to once you finish residency and fellowship. But if you're in training, or it's been a while since you've seen a patient post-op with high IOP, you have to kind of go through this process. So like, in terms of high IOP management, I don't think it's rocket science, in the sense that if usually the first step with all of it is to give medical management. The real question becomes, if medical management is not sufficient, then what do you do next, right? And I think a lot of that comes down to the mechanism. For example, with a patient who has gas and their IOP is high and they're not coming down, do you tap gas in those situations? Do you ever not want to touch the vitreous and tap the AC instead if there's room? What do you do, for example, if it's oil and you can't tap oil in the office very easily? How do you kind of troubleshoot those situations where medical management isn't enough if you are trying to avoid a return to the OR?
I mean, it's a highly nuanced issue to deal with. It's common. You see it all the time in retina stuff. So pressure a little bit low, pressure a little bit high, and I think there are a lot of teaching opportunities there. Like you said, understanding the mechanism is key, and then understanding the goal. Sometimes we want higher IOP after surgery. We want a good oil fill. We want a good gas fill. We'll tolerate a little bit higher IOP. If this person is advanced glaucoma and they have a 0.9 cup, you have to kind of dial that back, right? And so we have to just kind of understand the goal for this patient. We can tolerate IOP in the 30s for a young, healthy individual, otherwise for a while, right? Maybe even a little bit higher than that. But understanding the goal and then understanding the metrics, or excuse me, the mechanism. So if it's a gas, let's say you put in a slightly expansive concentration of gas, aqueous suppressants are probably not going to really cut the pressure down too much. They might help a little bit, but usually in that setting, I kind of just prepare the fellows for the idea that we might just need to put a little bit of a gas tap in there, which is not anything that's difficult to do. You stick a 30 gauge needle in there and just titrate it with the plunger out. It's not difficult, but understanding that mechanism can save you a lot of heartache, because if you're sitting there trying to give all these drops and Diamox and it's not coming down, you need to figure out why that is. It's not a matter of just throwing more drops at them. You need to kind of understand the mechanism here.
Do you mix your own gas, or did the fellow mix? Like, how do you guys handle that there?
Yeah, I mix the gas every single time. You'll see these case reports here and there about people where they think that non-dilute gas snuck into the eye, and they're nightmares. I mean, these people are pressure of 100 NLP just from ischemic optic neuropathy. I mean, these cases can go down the tube real quickly. So I mix my own gas every time.
So let's transition to the next little write-up. Christina Wang wrote this great article on sutureless scleral fixated IOL surgery. We've talked about modified Yamane or these sutureless approaches before, and she goes through it really nicely. I think it's a good article to review for anyone who's doing this technique, to kind of go through and just make sure you're hitting all the big points, which she did here. Chris, Shriji, I know this is a technique that you do and you have done. If you had to pick like one pointer, right? So she had a lot of these little pointers. What do you think is like the most critical thing that people routinely mess up with these cases that you want to tell people?
Yeah, I thought Christina did a great job with this article. The thing that stuck out with me the most, because I know I echo it a lot, is doing a good vitrectomy. That's, in my opinion, critical to preventing a lot of the bad postoperative complications that you can develop in this type of setting. Doing a good vitrectomy, peripheral shave, skull test, looking for any tears, lasering if necessary, because all these cases have really good refractive potential. They have good visual outcomes, right? But if they develop a retinal detachment, or you're trying to take a lens out and you cause a big tear, that can really change the trajectory for what this patient's course is going to be like. So I think doing a good, thorough core vitrectomy, and she even says, don't even worry about the lens until you've done a vitrectomy. I think that's some pretty good advice.
And then, I mean, for me, I think that's a great point. I think the other thing that is a really silly point, but I think people forget because they're so busy doing it, they're so excited, is when they're pulling the haptics, if you're using trocars, it's forgetting to take the trocar out when you're pulling the haptic, because that's what's going to damage that haptic. And it's, we don't usually deal in retinal surgery with binary fork in the road moments, right? Like phaco surgeons, they break bag, that case is now gone down a different path. Most of our retinal surgeries, unless you do something really bad, like you hit the macula with something, even then it doesn't really change your decision making that much in terms of what you're going to do next. It's just a bad outcome. But this is a case where, if let's say you're trying to rescue an IOL and the haptics look good, if you damage that haptic and it could have been avoided, now you've completely changed this case from a rescue to an explantation, a new IOL. So like, for me, that's one thing I always try to remember is like, hey, I know you're really excited that you got that haptic. Like, hold on to that haptic, take that trocar out, because if you just try to pull and yank it, next thing you know, you're going to have a haptic out of the eye and an IOL falling to the back. So that's always
Yeah.
something that I try to like embed in my brain, because I know it's kind of similar to Gore-Tex. Like, I think the silly thing in Gore-Tex would be when you're taking your trocars out at the end would be not stabilizing your suture as you do that and taking the suture with you, which I've seen videos of. And these are like
Yep.
silly things that completely change your day and completely change that case.
Yes, that is well said. It's happened to me. It's just when you get to that point, it's like you said, it's a fork in the road moment. These are small things that, if you pay attention to, can really change the outcome of the case. And so I think you said it well. Just being detail oriented, and something that this actually goes back to the complications article. Walking through the steps of the surgery in your head. I tell my fellows I do that before every case, even routine cases. I walk through every step one by one and just kind of make sure, because there's always little differences in vitrectomy cases. There's always pseudophakic, phakic, multifocal IOL. There's always these little differences, and so walking through each step, I think, really helps you picture what you want to do next. Things like pulling out the car, stabilizing sutures, and these little steps make a big difference in terms of surgical time and surgical outcome, in my opinion.
And I think the other thing is like, in terms of other things that people have talked about, I mean, do you do PIs for these cases now routinely? I know people have talked about this from Beaumont, that there may be a risk of UG or Shafe. I mean, how far back do you go? And then do you do a PI routinely now? Or do you wait to see and then add a PI later if you need it?
Yeah, I don't routinely do a PI. I just make sure that I can sweep behind the iris and that the IOL and iris are not in any way in contact. That's kind of how I do it. Make sure that they're just not in close proximity. Obviously, there can be a little bit of instability with these lenses, and they can kind of settle in a different position than when you leave it at. But I don't routinely do a PI.
So let's transition to this next article, which is about something we're not really using in the retina area, but it's interesting to hear about because I think we've heard about it from intersegment colleagues. So Dan Kiernan wrote this article about dexamethasone intracameral drug delivery suspension for inflammation following vitreoretinal surgery. This is the DexaQ kind of implant sphere by EyePoint. And he talked about doing it for vitreoretinal surgery. You put it in there, and perhaps they've talked about this in anterior segment surgery. Maybe this is a way to avoid needing a post-operative anti-inflammatory drop, similar to Trimoxy or these other formulations you can inject, and then a patient doesn't have to use drops. And there's different discussions we've had about how important that is. I think that the classic old school retina surgeon in us is like, just use your drops. Why are you doing something like this?
Sure.
But there are real reasons. Maybe it's difficult for patients to be adherent and compliant. There may be infection risks if the patient aren't applying their drops correctly or rubbing their eye with the plunge. I mean, there's cost potentially, although these things are not inexpensive as well to add in.
Yeah.
I mean, we can, and again, people can read about these different ones. Extenza is another one by Ocular Therapeutics. And he talks about maybe in the COVID-19 pandemic, it may be better because patients don't want to get medication. I think it's valid. I think the other issue, though, would be if they have a steroid response, then you have to think about that as well. Although the risk does not seem to be higher than with topical drops, at least based on the
Sure.
data that's presented. So but let's turn this to a more general question. In what cases do you give additional supplementary steroids at the time of surgery besides post-operative drops? So like a sub-Tenon's injection, intravitreal triessence at the end of the case. When are there, or like one of these implants? I don't know if you've used them. I haven't. At what point do you consider adding this to a case, and what cases are those?
Yeah. Really interesting article. Benefits that you would not necessarily think about. Some of our patients, I mean, I've seen them bottle-induced corneal abrasions. All sorts of issues arise from eye drop use. I mean, just missing the eye altogether. We see that pretty commonly as well. So I'm glad that they're looking into this. Yeah, it might be a little tough to incorporate into practice, in my opinion, for a few different reasons. But I'm glad that it's out there as a potential. In terms of steroids, if they're a patient with a history of uveitis, or if I'm doing it for some CME type indication, or let's say an ERM where I'm worried that there's going to be post-operative CME, I'll be quick to do like a sub-Tenon's catalog or sometimes an intravitreal triessence in those settings. But I don't do it routinely, and I certainly don't do it as a substitute for post-operative drops. Some of that I think is just a holdover from just practice and training and how we've always done it. I wonder how many of these patients actually truly need the post-operative medication at all. Or especially like even things like subconj, after at the end of the cases. All these things I've always looked at with a questioning eye, just because the evidence on it.
Post-operative topical antibiotics. It's like, it seems like heresy.
Exactly.
It seems like
Yes.
heresy to not do it, but there's no evidence actually if you go look at the literature.
Right. And
Yeah.
so it's just a lot of what we do in medicine is based on tradition and also anecdotal evidence, and not wanting to necessarily shift too much from what was deemed the standard of care.
Right.
But if we really walk it back a little bit, probably the drops are not as critical. But I'm not convinced that injecting is as safe because, like you said, there could be steroid response. The medicine could sometimes go where it's not supposed to. So there are certain risks that need to kind of be elaborated a little bit more.
Yeah, we can talk. I mean, that's interesting. We can talk about topical antibiotics in a second. I don't use steroid injections as a substitute either. I think scenarios where I'm more likely to use it, I don't do that many peds cases, but I'm doing a kid. I kind of assume they're probably not going to get the drops in as much. So maybe I'm more likely to use a
Sure.
steroid. I think patients who get a lot of laser or during like a retinal detachment repair or a full PRP, I'm more likely to consider it because those patients can get more inflammation. If I combo like a phaco with a vit, especially in diabetics, diabetics can get a lot more inflammation post-operatively.
Yeah.
Then I'm almost certainly going to use some sort of steroid. And then I usually use intravitreal actually because I think it's a little more potent. It may help avoid fibrinoid response, synechiae, other issues after those surgeries. Uveitis is a great point, and then I think patients reattachments is interesting because steroids have never been shown to reduce the risk of PVR,
Sure.
but I usually will add it at some point in the surgical course. So hopefully I don't have that many surgeries, but if they reattach early, especially and they're younger, I'll consider a steroid because at least I can eliminate one potential mechanism for
Yeah.
PVR, which is inflammation. Post-op drops, it's so interesting. We kind of have these schedules that whatever you learn in fellowship is like, you use this combo steroid antibiotic or you use a separate steroid antibiotic and you do it 4 times a day and you taper it after a week and blah, blah, blah.
Right.
I mean, it cannot possibly be one size fits all for every patient, and it should not be one size fits all for every procedure, right? So I think for macular cases, for example, do you really need to taper is the question. Like how inflammatory is doing a vitrectomy and an epiretinal membrane peel? And then the real question is, should you taper as quickly in someone else who may have more postoperative inflammation, like a diabetic or a retinal detachment repair where they had significant laser? Probably you could keep the steroid for longer. And we've all seen cases where you taper the steroid in those cases and you have to bump it back up because the patient develops inflammation. So those are my thoughts. I mean, antibiotics is an interesting one because there is no evidence.
Yeah.
It just seems so scary, quote unquote, both from like a personal responsibility. It seems like an easy ad, and then it would break your heart if they got endophthalmitis because even though you would not know that was the causative reason, but it
Yeah.
would
You'd always be
really,
questioning
really,
yourself.
you'd be kicking yourself, being like, why didn't I do it? And the second
Yeah.
is just the real legal possibility. Like, is there liability if there's no evidence? There could be if you have enough expert witnesses or a very qualified expert witness who goes up and says, well, the standard of care in this area is patients who have this sort of surgery should be on a topical antibiotic post-operatively.
Yeah, and I think the other thing too is it's not a big
Risk.
logical leap to think that you have surgery, you need antibiotics afterwards, right? Even
Right.
if we're like, well, it's not evidence basis, and maybe you're actually selecting for more
But we got
resistant
rid of it
bacteria,
for
but
we got rid of it for injections, though. I mean, that precedes us,
yeah,
but we were in training. Everyone was getting antibiotics after injections, and
it's
we all
true.
somehow came together and we're like, we don't have to do this anymore.
Yeah, it kind of takes that kind of group consensus to shift, I think. So I think it's going to take a lot of leaders in the field to be like, hey, we don't need these. It's not evidence based. We might actually be making outcomes worse. Let's try it, or like a large, wide scale trial, obviously.
Right. Yeah, I mean it's hard too because injections are primarily only done by retina specialists, right? So, but surgery, and we're doing vitrectomies, but surgery, which includes cataract surgery and glaucoma surgery and vitrectomy, is done by many different ophthalmologists, and the risks are not uniform for those procedures. So, for like on the other side of the coin, the intersegment surgeons, they're like, we need to decrease our endophthalmitis risk to the point where we're considering and using intracameral antibiotics.
Yeah,
And
right.
so the real question would be if we somehow, even as a retina community, came together and said, you don't really need to do topical antibiotics. I would just wonder if there would be confusion or an issue at some point where, let's say, an anterior segment surgeon refers the patient, they get endophthalmitis. Are they going to be like, well, how come you're not using drops? Every ophthalmologist I know uses drops. And that's where we fall into an interesting niche because we are a circle within the Venn diagram of circle of ophthalmologists, right? And there's a lot more ophthalmologists out there than retina specialists who are using drops. Again, there's no evidence for cataract surgery for topical antibiotics preventing endophthalmitis, but the rate of endophthalmitis is significantly higher and maybe justifies in people's minds using it. Also, given the low or no risk. I mean, I guess the only risk maybe mild epithelial toxicity and of course resistance, which is a real issue, but not a risk to the individual patient in that moment in time. So it's a lot harder to quantify.
Yeah. And I'll take it one step further. Even within retina specialists, we are ourselves our own separate like kind of Venn diagrams. So if I'm doing, like you said, just like a straightforward ERM peel, yeah, antibiotics might not be necessary. But what if I'm doing, a vitrectomy with an IOL explant and sutured IOL or secondary lens? I mean, that's kind of anterior and posterior. Am I more likely to put drops in because more incisions? I mean, it's a question. It's all retina surgery is not the same. Cases are always so different. And so, yeah, accumulating evidence on this topic is probably gonna be really tough, and that's gonna be a big barrier to breaking the quote current standard of care.
Well, we only got a couple minutes left. We're going to fly through his last article, Vitreoretinal Practice Patterns in the COVID-19 Era. Matt Starr, with a couple of attendings, David Zhu and Ajay Curry and friends of the program from Wills, wrote this. I'm not going to belabor this just because on the previous episode prior to this in the Journal Club, we talked about the article from Berzano et al. From Wilmer, looking at that decreased incidence. We talked a lot about the reasons for that, kind of strategies for it. I just want to get your 2-minute opinion, Sriji. So what do you think is the best way to approach this if we reach another point in time in our careers where there is this sort of medical pandemic significant shutdown? How do we best prevent delays in care for patients with retinal detachments, for example? Is it public outreach and education on social media? Is it talking to primary care doctors who may receive these calls from patients? Is it talking to referring doctors who may be closed in this issue, but telling them, hey, if you do get a call from a patient, you need to let them know to see us? Like, where do you think the gap is? Do you think the gap is in patients even knowing about the symptoms? Or do you think the gap is because the normal referral patterns are broken, then it doesn't happen?
Yeah, that's a great question. I'll tell you, I don't know if I have a one size fits all answer for that, but I think, God forbid this happens at some point in the future. My hope would be that our telemedicine capabilities are advanced enough where we can actually diagnose a little bit more. You and I have talked about this. Retina really, we tried a telemedicine, but it was kind of almost like a swing and a miss because it's just so tough to to do what we do over telemedicine or like really assess symptoms. Symptoms can be so vague and tough to kind of assess. And telemedicine versus the phone, is it additive? But if we had some capability of, let's say, taking a quick fundus photo or something like that, or reliable visual acuity checking, these things can actually be game changers in terms of how we can assess patients remotely. And in itself, that can give us a better idea about, yes, this patient needs to come in, this is a problem, or no, they're actually quite stable, stay at home, it's not safe.
Yeah, good points. And I think hopefully we won't have to deal with this again, but it's important to learn some lessons from this. And we're still seeing, at least here, spillover from the pandemic. Patients who
Absolutely.
couldn't get care or delayed PVR a year out. I mean, it's pretty drastic. And I don't think we're ever going to get good enough data to really capture all of it. I think we'll get pieces or the tips of the icebergs from different papers that come out. I don't think we'll ever have a good enough series that really captures all of the patients who were truly lost because we don't actually know the denominator, even as these patients trickle back in.
Yeah, I agree. We'll never really get a complete understanding of the amount of vision loss that was preventable because of all the different kind of workflow problems that arose from the pandemic. I think we'll never know. We know it's a lot, but we'll never know how much.
Dr. Patel, Sriji, thank you so much for your time. This was great. Hopefully
Thanks,
listeners
Jay.
enjoyed it. And again, you can get these articles online at retinalphysician.com. Sriji, until next time.
Yes, it's always a joy. Thank you, Jay.